Hello, everyone, and thanks for joining us today for the first LiveLung BRAF Lunch and Learn. So excited to have you here. My name is Katie Brown, and I am with LiveLung, and we are delighted to host this webinar on BRAF cancer, specifically focusing on the BRAF mutations. And our two advocates that are joining us today are BRAF lung and BRAF colon. And what does that mean? What does that mean for patients, advocates, and clinicians? So, thanks for taking time out of your day. Thanks for joining us for this really important conversation. And on behalf of LiveLung, thank you for being here. Our first speaker is going to be Debbie Pickworth. Debbie is the amazing advocate and founder of BRAF Bombers, and she learned that she had the BRAF mutation. So I would love for you to introduce yourself, why this is so important, why this Lunch and Learn is so important, and, why you became an advocate, and anything else you want us to know.
Thanks, Katie. So I was diagnosed, I'll give you a little history of me. I was diagnosed in 2013 with stage 4 lung cancer. I was 43 years old. I did not know at the time that I was BRAF until I went to my second opinion doctor, which is Dr. Gadgeel. And that is solely because I was not at a hospital that tested for anything other than actionable mutations. So I'm really thankful of the doctor I had at that time sent me to Dr. Gadgeel, and he sent it out for further testing, and I found out I was BRAF V600E. At that time of diagnosis, there was no treatment in lung for BRAF. So I ended up on chemo of carbo, Alimta, and Avastin. And I did that for 12 rounds minus the carbo after 6. I think it was 2015, late 2015, when there were trials out and I'd progressed for BRAF. And so I had to move over to U of M where they were doing trials. And unfortunately, I missed the lung cancer trial by 2 weeks. So I had a doctor there who knew how much I wanted those drugs. So he started calling around to other cancer types and found me a trial in melanoma, which I'm not sure if everybody's aware, but 50% of melanoma is BRAF. So I ended up on a BRAF trial, getting the drugs that I wanted, plus one more drug, which was the actual trial drug. And that did not have a name. It just had a number. I don't remember. It was been a long time. So I'd stayed on that trial for a little over 2 years. And I did not get kicked out of the trial due to progression because of the drugs. I got kicked out of the trial because of side effects due to the drugs. So I went back to the lung side and went back on Alimta, and I have been on and off that up until this past year, where I progressed again. This is my third progression, and I am now on the BRAF, Mektovi, Braftovi drugs. I'm actually doing quite well on those after a lot of trial and error with side effects. And my last CT scan was 80% reduction. So the reason why I started the BRAF Bombers was because when I was diagnosed and then I started a trial, there wasn't a whole lot of patient involvement on, patient to patient, because, being so rare in lung, that I wanted to talk to other patients that were on BRAF, and maybe I can help them because I was one of the original ones on a trial for BRAF. So I thought, and COVID was hitting and everything was shutting down. So I thought I need to be involved with patients, regardless of whether it's online or in person. So I started, at the time, it was just BRAF and Lung, a Facebook group. Not knowing if anybody would join, anybody would find me, and all of a sudden people started coming. And I think, Katie, there's 32 countries in that group right now.
Yeah, it's amazing. It is amazing. Well,
Um,
let me ask you something real quick, Debbie. When you did your biomarker testing, was that something you asked for, or did your doctor just do it?
no, all he asked for was for the slides.
Oh,
So I actually went to the hospital that did my biopsies and picked up the slides myself and brought them with me to at the
yeah,
time Dr. Gadgeel was at Carmanos. And no, I didn't know what he needed for, what he was testing for. I was way too new. I
yeah,
had no idea at the time what I was doing. I just knew that I had lung cancer and I wanted it gone.
yeah. And when you first learned about BRAF, what did you think?
My
Something?
first thought for me personally was because my mother died of lung cancer was, is this hereditary? It is not, but I do not know what my mother had. I knew she had non-small cell. It was 20 years prior when she passed away. She was also 49, I believe, when she passed away. So I'm going to say that when you're first diagnosed, there's like two types of patients, I believe. You got your newly diagnosed patients, and then you got your patients who's been doing this a while and they learn a lot along the way. When I was first diagnosed, I feel like it's a stages of grief kind of thing. So I knew nothing, but I know what my personality type is, and I knew I had to know everything. So that's what I did. This is my way of trying to help other people that don't know everything, don't want to know everything. They just want to know, there's many different types of cancer patients. So,
Absolutely, absolutely. And the wonderful thing about BRAF bombers, Debbie, is that they can go there and they can find you and they can find each other and they can have these real conversations. Like what are those slides for? What are the biomarker tests? What does that mean? What are clinical trials? So I think that's just it's so important to get folks asking their medical team these questions.
yep,
It's wonderful. Well,
yep.
thank you, Debbie. Stick around. There's going to be some more questions.
Mhm.
But and I know that they find your perspective absolutely meaningful and courageous and brave. And so we're going to move over to our first physician expert, Dr. Gadgeel. Hi, Dr. Gadgeel. I see you.
Hi, hi, Katie, and hi, Miss Pickworth. It's so wonderful to see you.
Nice to
I
see you
still
too.
remember your first visit with me so many years ago. I wanted to quickly start off by talking about a patient that is under my care and was diagnosed not too long ago. These were the scans when the patient developed metastatic disease. Actually, when the patient was originally diagnosed, the patient had a locally advanced disease, was treated with. One of the things to remember is as of now, the treatment we have for this BRAF V600E mutation positive lung cancer patients is mainly for patients who have advanced stage disease. If you have early stage disease, stage one, stage two, stage three, the treatment is very similar to other lung cancer. So the patient received chemotherapy and radiation and subsequently received immunotherapy for a year. But then a year and a half later, developed progression of disease with fluid in the chest and also developed liver metastases. I don't know if my arrow can be seen. So I'll come to this case a bit later on. Before I get into BRAF, I just wanted to put up two slides because I get this asked by most lung cancer patients when I see them for the first time. One is, how is it that you're telling me I have stage four lung cancer when just a month ago, 2 months ago, I was feeling perfectly fine and I just have a cough or some shortness of breath? And what I tell patients is, unfortunately, with lung cancer, a good proportion, I would say about 40-45% of the patients at diagnosis of advanced stage lung cancer. And that proportion seems to be higher in never smokers. And one of the reasons, a couple of reasons why that happens is that we have two lungs. So you can have something growing in one lung and you are not going to know about it because the other lung, other portions of the lung and the other lung can compensate. We don't need two lungs. People have run marathons on one lung. And the other issue is that we don't have pain nerve fibers in lungs. So if something is growing in your skin or in your muscle, it is going to stretch the pain nerve fibers in the skin or muscle and cause pain, and you're going to perceive that pain. But we don't have pain nerve fibers in the lungs because our lungs constantly move. We breathe in and out. If we had pain nerve fibers, we would be in pain all the time. And so again, you could have something growing in your lungs and not know about it, and it may not affect your breathing until it is fairly advanced and has spread to other areas and causes symptoms there. Even though the symptomatology might have been present only for a few months before diagnosis, the process generally has been going on for a very long period of time. And the reason I usually tell this to the patients is this is not a cancer. There are cancers where you need to be admitted to the hospital as soon as you get diagnosed because the urgency of starting treatment is very critical. But in lung cancer, in most cases, there are some patients where you need to get really going right away. But in most patients, you have time to figure out what is the profile of the patient's lung cancer and start treatment based on that understanding rather than rush into some treatment. And then the other thing is lung cancer can spread to any part of the body, but the common sites are lung itself. It can spread to other parts of the lung, the same lung and the other lung, adrenal glands, liver, bones, and brain. And something that Miss Pickworth had is metastases to what is called as the pleura, the lining of the lung, where the patient can develop pleural effusion. Now, I want to tell you that this doesn't mean in all lung cancer patients it goes to these areas, and doesn't mean that lung cancer couldn't metastasize to any other part of the body. But generally, these are the sites that, if a lung cancer is going to metastasize, these are the sites that it metastasizes to. And this is why the scans that we do are primarily directed to assessing these organs. Because if you're going to find metastases, that's where you're going to find metastases. So that was generally about lung cancer. Very briefly about BRAF positive lung cancer. And I'm going to try and not get too technical, but it's important to recognize that there are different types of BRAF mutations. And there's something called as class 1, class 2, and class 3. About 50% of BRAF mutation positive lung cancer is class 1, which is what Ms. Pickworth had, and which is for which we have what we call targeted treatment. We do not, as of now, have targeted therapy for class 2 and class 3 BRAF mutations. I do want to say that there seem to be a little bit of difference in the type of patients who have BRAF mutation, class 1 mutation positive lung cancer as opposed to class 2 and class 3. There seem to be no more never smokers in patients with the class 1, the typical BRAF V600E. Class 2 and class 3 generally tend to be more likely to be current or former smokers. Doesn't mean you can't get that in never smokers. Overall, Dr. Ms. Pickworth mentioned 50% of melanomas are BRAF mutation positive. In lung cancer, that's about 1 to 2%. So it's not a very common subtype of lung cancer. And 50% of that, again, is class 1, the one for which we have targeted therapy. I'm not going to get into the technical aspect of what is class 1, class 2, class 3. Suffice to say that the treatments we have right now, targeted treatments, don't work in class 2 and class 3. Even though all these are BRAF mutation positive lung cancers, mutations rather, the targeted treatments we have only work in class 1, don't work in class 2 and class 3. Having said that, and I'm going to come to this, there are drugs in development that are going to that may work in class 2 and class 3 BRAF. So it may not be sufficient to know that your cancer has BRAF mutation in your cancer. It is important to know what type of BRAF mutation you have. And secondly, BRAF is one of those mutations that occurs in a variety of different tumors. It can occur in lung, it can occur in melanoma, it can occur in colon cancer, it can occur in thyroid cancer. And so at the present time, again, the class 1, the one mutation that was present in Ms. Pickworth's cancer, is the more common one. And if that is present, irrespective of what site of the disease it is, the targeted therapy is an option. If it is a different BRAF mutation, class 2 or class 3, targeted therapy is not an option. This slide is supposed to, and I'm going to try and not be too technical. What is important to note is you give a combination with many of the targeted treatments in lung cancer. You give a single drug to target the mutation that the patient's cancer has. BRAF is one treatment where you give two drugs, and the reason is one, actually, the shrinkage of the cancer is better when you give the two drugs because of variety of changes that occur. If you give only one drug, the cancer can easily learn to overcome that. And so to really provide benefit, you have to give two drugs. But what is maybe even more important, that if you just give one drug, you can see sometimes more side effects, including these skin tumors or even skin cancers. So if you give one drug, there is some changes that occur in normal tissue. And to prevent that, you have to give the second drug. So the reason we give combination treatment is not only to improve the benefits of treatment, because one drug is not sufficient generally to control the cancer. But also, if you just gave one drug, you may actually see side effects, including skin tumors and skin cancers. I was treating a 90-year-old lady. I was a little worried about giving combination treatment as to how she was going to tolerate. So I gave only one drug just to see how she does, one drug. And within 2 weeks, she started showing these skin lesions. That was quite surprising. So it is very important that you're getting both drugs. These are the two combinations that are now in use. The first combination that Ms. Pickworth was on, that we've been using for some period of time, is this combination of dabrafenib, trametinib. But now we are more and more using this combination called encorafenib and binimetinib. And there's data to suggest that this combination may be better. The encorafenib and binimetinib, the median progression-free survival with this was almost 30 months, whereas it is about 11 months with dabrafenib, trametinib. It is not really clear why it is so much better with this combination of encorafenib and binimetinib, in that we don't have any clear evidence in animal models or in cell lines that this combination necessarily provides better control. But yes, in clinical trials, there did appear to be better benefit with this combination, and because of that, that has become the default. That has become the more commonly used combination. I also want to mention that one of the sites of metastases for lung cancer, also for melanoma, are brain mets. And there is evidence that this targeted therapy could be effective in brain metastases patient also. This is a case report from University of Virginia that showed that this combination of encorafenib and binimetinib could be active against brain metastases. Traditionally, we have used radiation to treat brain metastases, but more and more we are using these targeted therapy agents to treat brain metastases without necessarily doing radiation upfront. Now, this combination, I will say, compared to other targeted therapies that we use in lung cancer, does have more side effects. One of the unique side effects with the dabrafenib, trametinib, the combination we used to use more commonly in the past, is fevers. Fevers could be as high as 102, 103 degrees Fahrenheit. And that could be a challenge. And we had to many times reduce the dose or interrupt the drug. You generally don't see fevers as commonly with encorafenib and binimetinib. There are other side effects of nausea, vomiting, diarrhea, and I completely agree with Ms. Pickworth that when you use these combinations, either of them, there is a bit of trial and error period, and it can be somewhat challenging for the patient to kind of go through that, in that we sort of reduce the dose or hold the drug, or sort of have to come to an understanding what is the right dose and schedule for a particular patient. So there is a bit of time that is required to figure out. So we start off with the standard doses, but then have to make adjustments over the first 1 to 2 months. As I mentioned, there are new generations of these targeted drugs for BRAF mutations coming along. This is one drug that we are working with. This is from Pfizer. And this has shown benefits in patients who were treated with previous generation targeted therapy. and had the cancer had progressed, and the drug in combination with a drug called binimetinib has shown benefit, including in the brain. And so there's hope that these drugs won't just be effective in the class 1 BRAF mutations, but also in class 2 and class 3, for which we as yet don't have targeted therapy. Now, with most lung cancers, we tend to use immunotherapy or chemo plus immunotherapy. And what about BRAF mutation positive lung cancer? What should we do? Should we use targeted therapy first, or should we use chemo plus immunotherapy? And this was a retrospective analysis, so this was not a prospective trial, so one needs to review with caution. And it looked at BRAF V600E, so the class 1 mutation. And they found that in this retrospective analysis that maybe there was slight advantage to starting off with chemotherapy and immunotherapy as compared to targeted therapy. But I think what is very important to note is if you look at smoking status, that is, if somebody was a current or former smoker and particular heavy smoking history, they may actually have a possibility of greater benefit with chemotherapy and immunotherapy, whereas if somebody was a never smoker, then they would likely more benefit from starting off with targeted therapy. So we do take into account a variety of factors. At the present time, we don't have conclusive evidence which is the better treatment. Is it targeted therapy or chemo plus immunotherapy? And one needs to individualize based on the different features of the patient's clinical case to decide what is the right treatment for a particular patient. I just wanted to mention, this is a slide I've taken from another presentation on ALK positive lung cancer. What I do want to say is as patients are doing better, I've been doing this for 25 years, and I can tell you the outcomes of lung cancer patients were not so good in the past when we had only chemotherapy. And so our entire focus was on lung cancer. But as the patients are starting to do better, it has become very important that we take into account a variety of other health issues that the patients may be dealing with, because these patients are living longer. And it doesn't help the patient if we are just focused on the lung cancer and not looking at the overall health of the patient. So this is a presentation from ALK, not from BRAF. I want to say one of the drugs causes weight gain in these patients, and that can be cumulative over years. And so it has become important that we include lifestyle modifications right from get-go as part of the management of lung cancer, so that not only these patients are living longer, but that they're able to live a more wholesome life. I just wanted to finish up with this patient of mine who was diagnosed with this treatment with metastatic disease. So again, diagnosed with stage 3 disease 2022, got chemotherapy and radiation, immunotherapy completed in 2023, and then developed in December of last year metastatic disease. And she's on encorafenib and binimetinib, and as you can see, she's almost a complete response. You don't see the effusion, and that liver metastases has completely gone. Now, is this every patient? No, it is not. And it did take us about 6-7 weeks to figure out what was the right dose and schedule for this patient. But what I wanted to say is that there is hope for these patients, and more importantly, there are a lot of new drugs coming along that are currently in clinical trials. So I wanted to sort of briefly cover what BRAF positive lung cancer was, and sort of just hopefully this generates some discussion points later on. So thank you very much.
Thank you, Doctor. That was very clear, and I appreciated that very much. We do have some questions, and I would love to get your perspective on. I know we're not providing medical advice, so I'm going to try to summarize the question, whether or not you have any advice to share.
Sure.
Okay, so I see a question about the top side effects of Bractovy and Mektovy, that those have not been tolerable to this person. I think this person wants to know if that's common, that people have side effects that are intolerable.
Yes, the side effects are not uncommon with these combinations. What I can tell you is that this requires a lot of a little bit of a trial and error, as Ms. Pickworth was saying. So I just to give an example, and again, I'm going back to that 90-year-old patient that I treated. And at the end, she was on one-fourth of the dose of both drugs, of the standard dose, and she would take it from Monday to Thursday and skip Friday, Saturday, and Sunday. And with that, her cancer remained controlled for about 18 months. It's not just dose reduction, but sometimes what you need to consider is to do intermittent dosing. The concept is to do continuous dosing. But what we have never shown with any of the targeted drugs is that you necessarily need continuous dosing. Now, of course, if the patient is tolerating well, we have the patient take it every day, no question, and that would be the right thing to do. But with some of the targeted treatments, including these BRAF treatments, sometimes what we need to do is um, give sort of very brief breaks, even weekly breaks, where sometimes I've told patients to do Monday to Friday, skip the weekend, or skip Sunday. There is a patient of mine who works as a radiology technician, and she takes lower doses from Monday to Friday, and then takes higher doses on the weekends when she's not working. So what I'm just saying is that, yes, toxicity is not uncommon and there are ways to manage the toxicity, but I think the most important way to take care of the toxicity is to, make dose modifications and schedule modifications.
Okay, that's great. Uh, Atrial fibrillation. Okay. Do you ever see a scenario, trying not to do the medical advice thing, do you ever see a scenario where someone may have recently developed atrial fibrillation, but is now in sinus rhythm, whether or not they would be able to continue immunotherapy?
Immunotherapy, yes. I don't see any reason to not continue immunotherapy. Sometimes with targeted therapy drugs, there can be drug interactions with drugs that may be needed for other medical conditions, such as atrial fibrillation. And so one needs to be mindful that I can tell you one thing, that there's so many drugs that we use, not just in cancer now, in other conditions also, that pretty much anytime a patient is starting on a new drug, whether it's a cancer drug or a non-cancer drug, I actually discuss it with our pharmacist. So we have a pharmacist who focuses only on lung cancer patients. And I seek advice from her as to, are there any drug interactions with the treatment? But yeah, I don't see any reason why the patient couldn't continue on immunotherapy.
That's good to know. Very good to know. Another question, which biological markers or laboratory tests do you recommend for monitoring and early detection of recurrence?
So that is a presentation in itself, to be very candid. What I can say is at the present time, we monitor and do surveillance using CT scans or PET scans, radiology scans. That is the standard. Having said that, there is a great deal of interest in using what is called as circulating tumor DNA. But I want to be cautious about what I say, because we really don't have data as of now that doing surveillance with circulating tumor DNA provides any advantage over doing surveillance with just radiology scans. And that if you detect recurrence through a circulating tumor DNA and decide to change treatment just based on that provides any longer cancer control or survival, as compared to only deciding to make changes based on radiology scans. There is hope and expectation that in the future it will be another tool we will use. But at the present time, I think it is not something that I would do in all patients.
Okay. Is the BRAF V600E mutation hereditary, and do children of patients need to get screened?
So, very briefly, the mutations we are talking about are something that the patient acquired during their lifetime.
Oh, okay.
We use the technical term of somatic mutations and germline mutations. So, germline is something that you inherited from your parents. But what we are talking about are called somatic mutations. That is something that the patient, for reasons we don't completely understand, why did a patient with BRAF mutation positive lung cancer acquire that mutation, BRAF mutation in that portion of the lung? We don't know. It is important to note what's the difference. So if somebody has a germline alteration, and BRAF mutation is not a germline alteration, but you may have heard of terms like BRCA, the BRCA1 gene or things like that, or Lee-Fraumeni syndrome. But there, if you test any cell of the body, that mutation will be present. Whereas BRAF mutation will only be present in the cancer tissue. If you sampled the normal lung and tested the BRAF gene in the normal lung, you're not going to find the BRAF mutation. So this is something that is only present in the cancer, and this is not something that you inherited from your parents or that you would be passing on to your children.
That's very important. That's very important to know. We have another question. Thank you so much for
No
being here,
worries.
Doctor. Um, Immunotherapy in BRAF, regardless of PD-L1, works better. Is this true?
When you look at all the gene alterations that are called the driver gene alterations in lung cancer, in general, in driver alteration positive lung cancer, immunotherapy doesn't work. The currently available immunotherapy, there are many other drugs coming along. So, what we call checkpoint inhibitors don't work as well. The exceptions are KRAS mutation and BRAF mutations. Not that it works in all the patients with KRAS mutations and BRAF mutations, but the likelihood of checkpoint inhibitors working is somewhat higher. Having said that, there does seem to be some difference, the data suggests, between patients who are current or former smokers versus patients who are never smokers. So immunotherapy is more of a consideration in BRAF mutation positive lung cancer, let's say compared to something like EGFR mutation positive lung cancer or ALK positive lung cancer.
If someone has the V600D mutation instead of E, can these drugs be used?
So it is exceedingly important that we know whether it's a class 1 or class 2 and 3. Generally, all the 600 mutations are class 1, and those targeted treatments can be used. But even for 599 is not a class 1 mutation. So it needs to be very clear what mutation, BRAF mutation you have. And not all BRAF mutations are the same.
Thank you, Dr. Gadgeel. Thank you for your time. Thank
No
you for your
worries.
expertise. And we look forward to seeing you in person next time.
Yes, thank you very much.
Thank you. We are going to move on to our second patient advocate. This is Annie. Annie Dolores. Are you here? There she is. Annie, thank you for being here. Introduce yourself. Let us know what you would like us to know about you. And we'd love to know about your research advocacy and your work with the BRAF Poland folks. Welcome.
Hey, thank you for inviting me to attend. There's so much to learn from other cancers. It's fascinating to find out what's going on in lung cancer. I'm mostly involved in colorectal cancer. My first two loves in research were immunotherapy and BRAF targeted treatment, but BRAF really relates to KRAS. So I've become part of KRAS kickers, and there's just a whole array of things going on, and but there's differences. And so, like in KRAS kickers, we're there's an orphan drug approval for pancreatic cancer for KRAS, a KRAS trial, but it's like it hasn't been proven yet in colorectal cancer, and there's going to be differences and responses, and so I'm trying to learn from other cancers, but also like putting out there like what a lot of people with BRAF are dealing with a lot, and so I think the need for support is really big, to find other people on the same treatments, because you're not going to be getting the same side effects. You're going to be talking about a rash, and people on chemo are going to be going, what are you talking about? And the same thing is if you're on immunotherapy, you're going to have your own set of side effects. So just to so I've been involved since 2016, and so in colorectal cancer, for stage 4, it's about 8 to 10% have BRAF mutation. So it's a little bit bigger. However, I think it's fair to say it's the most aggressive mutation in colorectal cancer, and things can move really quickly. There's some people who don't even make it to the second line of therapy. So we had a lot of really dedicated oncologists who focused on getting research done. So, Dr. Gadgeel was talking about the Pfizer drug Array, like 44 something. That's from Array Pharmaceuticals, which came up with the Beacon doublet, and then Pfizer bought them. And Pfizer, which is why Pfizer is a big name in BRAF, is that the BRAF researchers in colorectal were able to show enough benefit, better than second line, that it got FDA approval. And now we just recently got FDA approval combining Beacon, which is the BRAF inhibitor plus an EGFR inhibitor plus chemotherapy, and getting such longer. The whole overall survival has just changed dramatically. The potential for things to be, much better. Still, not everybody is going to have a response, and there's a lot of variety. So, we have 90% of the stage 4 patients with BRAF have a class 1 mutation. So it's only 10% have atypical. So we have to learn from melanoma. We have to learn from lung cancer, what you guys are doing, because we don't have as many, things in our toolbox. But then it's also going to be really, different. So in, a MEK inhibitor didn't seem to work out for colorectal cancer, whereas an EGFR does. And that's, I don't really know the science, but I know that it keeps on happening in KRAS and trials too. We can't be like melanoma and just have a single inhibitor. We need a dual MAP kinase pathway blockade. So I find all this stuff interesting. Maybe other people find it boring. I do know that I probably would have found a lot more of this boring, when I first started. And I believe you have to follow your scientific muse. At one point, I didn't care a bit about Lynch syndrome, and I was really busy at work, and somebody was like, what about Lynch syndrome? Was and now I'm in a Lynch syndrome group, and and post trials. And so I really know a lot about trials. And so before this meeting, I was trying to ground myself. And so every day I check clinical trials for updates, and there's a new BRAF trial, phase 3 from Pfizer that just got announced today. No location, 800 patients, phase 3. And I'm going, okay, there's something to post today. So part of the reason I have the BRAF library is that the science does keep moving forward. But if you only pay attention to Google or PubMed, you're not going to know, because they haven't, the papers haven't been published. The results haven't been proven. And, there's going to be trials, and it's not going to be proven yet, but it might be a better option than the standard of care. People can find it first diagnosed, and when just, there's just so much, somebody had a KRAS G12V mutation and was oh, it's really aggressive. And, yeah, maybe it is.
Right.
Anyway, that's enough about me. But I hope that there's things I can add to the conversation. It was great to hear about ctDNA. It's a big deal in colorectal cancer, but as the doctor said, nothing's been proven yet. But we are looking for minimal residual disease trials that might help for the future.
So tell us a little bit more about the BRAF colorectal cancer library. I mean, it sounds like for someone who has the BRAF mutation that you have to dive in. You have to learn a little bit about the science,
You
Tell
need
us
to
a little
find a
about the
nerdy
library.
friend to do it. You need to find a nerdy friend to do it. A family member who feels guilty, who's across the country, who's somebody who's really good at looking things up on Amazon or
Yeah,
eBay. Uh, because a lot of research, it's really just like being a librarian. It's being able to handle databases, and to me, Facebook and Twitter are databases, and I search them every day, and I find things
yeah,
every day, and um, I think that so there's going to be a lot of different coping mechanisms, and I know a lot of people are. So if you're getting biomarker testing, especially if you're stage 4, I think you actually sort of need counseling, just regular therapy counseling, because depending on what you find out, it might be overwhelming. And I think BRAF is an overwhelming um, diagnosis in colorectal cancer. And so you just need more support. And you also need to take ChatGPT with a lot of grain of salt. And you need to ask questions like, is there any new research in BRAF? Is anything
right,
happening since that if it,
right,
like you don't want to be rely on information from PubMed in 2015. So
right.
um,
Yeah.
things do keep moving. It seems really slow, but they do keep moving.
Well, I just want to thank you for being on it, for being, the nerdy friend and the BRAF information in the library. It's absolutely impressive. And I love how you were so willing to collaborate with Lung. And we are just we're just grateful that you're with us. And we'll together, I think we can really share a lot of information and empower a lot of patients.
Well, hopefully, when you guys move the needle, it shows up in colorectal cancer and in grants
Yes.
that we get, and vice versa.
Right. That's awesome. Well, thank you so much, Annie.
You're
Stick
welcome.
around. There's still more questions in the chat, and it's just really impressive and inspiring to hear the dedication that you have, and that it reminds me of Debbie in the lung group, and I think together we can really help a lot of folks. Okay, so now we move on to our final speaker. Dr. Vaishnavi, am I saying that right?
Yes.
It's a beautiful, beautiful name. You will talk about your work, maybe some future things that might be going on, or maybe I don't know. Tell us all the good stuff that you're going to share with us today.
Of course, I'd be happy to. So my name is Arya Vaishnavi. I've known Debbie for a little bit. I've spoken to the BRAF Bombers before. So I'm a lung cancer researcher who focuses on BRAF. And so I did my postdoctoral training with Martin McMahon. Can you guys see my screen?
Yes.
Yes.
Yeah.
Okay, great. Just making sure. Okay, great. So I did my postdoctoral training with Martin McMahon, who's a BRAF expert. He's a living legend. He's the guy who made the BRAF mouse model and a lot of the tools that we use today to study this. And so I specifically wanted to train with him as a postdoc, and now I run my own research lab, which is pretty focused on this. So I hope I can share some stuff with you. It might be a little technical sometimes, but I'll do my best to explain it really clearly. And if you have any questions, I'd be happy to answer them. So I'm a new assistant professor in the Department of Genetics and Thoracic Oncology at the MD Anderson Cancer Center. And I just want to thank you guys for this opportunity. I'm super excited to chat with you for a little bit about what I know or what my lab does. And so this is a schematic to show you what my lab research is. So we primarily use mouse models to understand how lung cancer initiates, maintains, or progresses. And we use this particular mouse model, which I'm going to talk to you about a little bit, which is a model where mice can conditionally develop lung cancer, specifically in the lung, and it's called an autochthonous model. And we also have some other models, which are PDX models, which I'll share with you as well. And just the ways that we're trying to model and make new models, better models. Historically, people have often focused on V600E. And one of the things that my lab is doing is making new models. So we're actually working on modeling the class 2 and 3 BRAF mutations right now. We have a big grant funding sourced for us to do that. We're also focused on understanding more about minimal residual disease. That's popped up a couple of times. But we have these cool mouse models that allow us to initiate tumors in the lung. And then we can treat the mice with the same drugs that patients get. And then at the end, there's that little bit of tumor that's left. We call it minimal residual disease. Some people prefer the term drug tolerant persister cells. And we're studying that residual disease because that is the roots from which drug resistance comes from. If we cured cancer up front with a targeted therapy or an immunotherapy, there wouldn't be minimal residual disease. And so we believe that understanding that residual disease is super important. And so I'm going to tell you a little bit about how we're doing that. This is a chart showing you that about 20, 30 years ago, lung cancers were categorized and treated based on histology, which you can see here in this pie chart. But over the last 10, 20 years, we've started to reclassify this disease based on molecular subsets. And the first two that came up were KRAS and mutant EGFR. And now we know that lung cancer is a heterogeneous disease at the molecular level. And this is a breakdown of the events, the molecular events that drive lung adenocarcinomas, which is what my lab studies. And collectively, this schematic shows you the evolution of how lung cancer has changed and how we think about it over the last few decades. And now it's exciting. We have 11 FDA-approved biomarkers, including BRAF V600E. Estimates say that about 5% of lung adenocarcinomas are BRAF mutations. Less than 50% of those are BRAF V600E. But one thing I want to emphasize is that lung cancer is an abysmal disease. So 1% of lung adenocarcinoma is 2,500 patients in the United States every year. So 5% of lung adenocarcinoma is a huge patient population. So 8% of human cancer has a BRAF mutation. And so I would argue that there is an urgent need for studying atypical BRAF mutations, which we're doing. But if you're thinking about this, even if 50% of melanomas have a BRAF V600E mutation, the 5% in lung cancer is a higher patient population, which is kind of crazy if you think about it. So I've been working on lung cancer for a long time now. I did my PhD in this and my postdoc, and now my lab studies this as well. But I want to talk to you a little bit more about BRAF specifically. And so this is a review that we wrote very recently. It came out last year. And it's looking at BRAF as a signaling molecule. It's an important component of the MAP kinase signaling pathway. And as was briefly touched on, we have class 1. Those are mutations that occur at the V600 codon. We have class 2 and class 3 as well, which I'm going to tell you a little bit about as well. The nice thing about this schematic is you can also see all of the inhibitors listed here, which have efficacy on the different types of mutations. Okay, so class 1 V600E is considered a RAS-independent mutation that signals as a monomer, which means it can signal by itself. And these are the drugs that work really well, whether they're early first-generation BRAF inhibitors or later on we have pan-RAF or paradox breaker inhibitors as well. Class 2 mutations are still activating mutations that are thought to be RAS or can be RAS independent, but they signal as dimers, not monomers. And class 3 are also dimers. They are not RAS independent though. They need some help from upstream signaling or a constitutively active event downstream or upstream, depending on what it is. That can result in a loss of negative feedback loops. And signaling is an interesting thing. So my lab spends a lot of time studying this, and it can be very technical, but it's important to consider the pathway and how these drugs are inhibiting the pathway and how successful they are. We heard a little bit about paradox breaker inhibitors. That's the reason we do vertical inhibition strategies in lung cancer, because these inhibitors accidentally or paradoxically can activate BRAF or BRAF-CRAF monomer, or not monomers, homo or heterodimers. And so it's important to add on a MEK inhibitor, which functions right here, which can be trametinib or binimetinib. And this is a cartoon I really like that came out a couple of years ago. And we're looking at the percent of BRAF mutations that occur in these particular cancer types. Also, what percent and B are V600 versus non-V600, as well as a more specific analysis, including the breakdown of class 1, 2, or 3 versus unknown. And I've highlighted a red box here around lung cancer. There's a high percentage of non-class 1 mutations in lung cancer. And as was also mentioned, only V600E patients have a targeted therapy that's FDA approved. And so my lab is now modeling class 2 and class 3 BRAF mutations in mice so that we can test therapies and hopefully get something approved within the next 5 to 10 years. That's the goal. And the nice thing about working at MD Anderson is the largest lung cancer clinic in the world, and it's also the top cancer center. So we are paired up with some great physicians over here at MD Anderson. And so any discoveries that come from my lab, we're working very closely with the clinic to see if we can translate them. And that's one reason my lab's focus is to make things as physiologically relevant as we possibly can. So I'm going to come back to the class 2 and 3 BRAF mutations in just a second. In the interest of time, I'm going to go kind of quickly and just share some information with you on what we've learned about targeting BRAF mutations. And so as you know, BRAF inhibition has been super successful in melanoma, targeted inhibition, but not so successful on its own in colorectal cancer. And the reason for that is we had to add in an EGFR inhibitor for it to be successful. In colorectal cancer, that's cetuximab, but not as much was known about lung cancer regarding this. And so one of the areas my lab is focused on is understanding potential crosstalk between EGFR, shown here at the plasma membrane, and the V600E oncoprotein. So to model this, we have a mouse model that we made, which is a conditional knock-in allele. It allows us to turn on lung cancer that's driven by BRAF when we want to. So that's really important. It's not when the mouse is born. It's when we decide to give it CRE. We deliver it with a virus, and that induces the V600E mutation in exon 15. That's the most common, not exclusive, but the most common, and the one we have right now. We also have engineered a TD tomato reporter, which turns these tumors red. It allows us to monitor this in a few different ways, which can be really helpful. And when we turn this on in the lung, you can see that it elicits multifocal MEK-dependent tumors with a short latency and 100% penetrance. This mimics human lung cancer. And so we get these benign adenomas without any corroborating mutations. And these mice are very sensitive to dabrafenib plus trametinib, as well as benimetinib and encorafenib as well. It does result in residual disease. So if we take them off of the drug, tumors come back. And so this really mimics what we see in human cancers, but this is how the lab can use these models to study this. And so an example of a type of experiment that we can do using our mice is we turn on the lung tumors the way I just showed you. We randomize the mice after 8 weeks onto vehicle or dabrafenib plus trametinib. And then we can do analysis of the tumors or what's left over and understand how different transcriptional programs in the mouse are regulated by BRAF V600E signaling. Now, this isn't our only tool, so we use the genetically engineered mice. But when I started my postdoc and my own research program, there weren't a lot of lung models available. And so we've worked with a lot of thoracic oncologists to create new PDX models and new genetically engineered mouse models, which allow us to mimic human tumors. We take human tumors, we put them into the mice, grow them up, and we test different therapies. And so that's the way that my lab is doing this, by combining dabrafenib plus trametinib with EGFR inhibition, which here is shown with afatinib. And we look using Western blotting to look at the signaling effects. We want to make sure that we're blocking the right pathways and that they're very potent against the right markers. Here, the big readout, the important thing that you can see here is a reduction in phospho-ERK. That's a readout for signal transduction in the appropriate pathway. When we combine BRAF and EGFR in lung models, we see an improved effect with the triple combination compared to each of the single agent alarms alone. And you can see that also in terms of the tumor burden. So EGFR inhibition was previously not appreciated to be as important in lung cancer, but it turns out that it is. And we're we're working on testing this in additional models, including xenografts from human cells as well. You can see here that when we randomized a lung clinical trial, the combination was superior at suppressing grow back from these tumors as well. And just briefly, as I'm wrapping up here, this is my last slide, to show you this is what the BRAF kinase protein looks like. And while people have previously modeled V600E, shown here in purple, we're now modeling class 2 and class 3 BRAF mutations, as well as some atypical ones, like the deletion that can occur in pancreatic cancer, deletion 485 to 490. And we're making a large number of mouse models so that we can appropriately study and understand how they work, how they signal. And when we know that, we can understand how to target them better. Because my lab's goal is to make physiologically relevant models and then try to block the cancer, to try to beat the cancer. And so we're actively working on this now. And I'm hoping that in the next couple of years, we'll have some really exciting data to share with you again. And that's it. I just want to thank my lab members and the physicians that we work with and our funding sources. And with that, I'd be happy to answer any questions you may have.
Are there any current trials in BRAF for lung right now going on that are with, I know you were talking about the EGFR, but is there anything going on currently in lung and for BRAF?
There are actively lung trials going on right now testing different targeted therapy approaches and also combining it with chemotherapy or immunotherapy. I'm not aware of anything super promising yet. We are working on translating some of my lab's finding with the help of the clinic, but we haven't found the right combination yet. It's one of the reasons we spend a lot of time understanding mechanistically how the signaling is going on, because there might be better combinations than using, so like, for example, we used afatinib, which would not be a possible combination therapy because it's toxic. We used it to understand mechanistically why or how the pathway is working because it was the best choice for us to understand the mechanism. But the next step is we want to understand the best, least toxic, and the best potent combination therapies to push forward clinically. This is more of a how does this work? How can we block it kind of a thing? And understanding how these proteins crosstalk and work together is a bit slower. Right. So this would never get put into clinical trials because combining dabrafenib, trametinib, and afatinib would be super toxic. And we know that. And we're working with our clinical mentors and guides to help because sometimes we make choices in the lab to understand how something works. It's not as relevant to the clinic. And working closely with our thoracic oncologists helps keep me in check. Is this a clinically relevant drug? Oh, you know what? There's a new drug that's coming up from the system from Pfizer. Maybe we should look at that and try to understand if that one would be a better target because it won't be toxic. For example, in colorectal cancer, they use cetuximab. That's not something we can use well in vitro because of the nature of how the drug works. But we are testing it in our mice now as a potential combination target. And we work closely with Scott Kopetz, who's one of the leaders for colorectal BRAF. And we're constantly talking and in communication and trying to understand what the best potential overlap or ideas would be for us to work together in understanding this better. Because there's a lot of overlap between BRAF colorectal and BRAF lung. And by creating all these new models, we can share information with each other a lot, which is one of the awesome things about working here at MD Anderson. Everybody's really nice and everybody's goals are to help patients. And so teaming up with these incredible clinicians allows us to learn more faster. And to apply it to patients quicker because Scott has the ability to translate these things to colorectal cancer faster than anyone else. Whereas John Haymack and Marcelo Negrão have the ability to translate this in lung cancer faster than other people might be able to. And so working together is amazing. And my lab has the ability to model things that will help them and to give them the information they need to pair up, right? So it's a great collaborative effort here. And I learn a lot from them. They learn a lot, hopefully, from my lab. And we'll have more in clinical trials soon.
I love it. Thank you so much.
Can I add a shout out to Dr. Kopetz? He's been really great in terms of like leading the Beacon trial and the Breakwater trial. But like, like in patient groups, he's actually like put together like an atypical BRAF, explanation for in colorectal cancer so that people could understand class 1, 2, and 3. And he's been incredibly helpful. There's somebody was asking a question about new breakwater, and he, about irinotecan, and like had an answer. And he's part of Colorectal Cancer Alliance, Cure CRC, and they're funding a lot of BRAF research that hopefully will help.
Yeah, God's a wonderful human being. I'm not saying that not all researchers are, but Scott particularly is a wonderful guy. He's just really warm and friendly and really caring, and it's been a joy to interact with him. The nice thing is that a lot of the models my lab is making can be applied to different cancers, and so if we make hopefully, good models for some of these atypical BRAF mutations, they can be applied in a tissue specific way, which is really important because these tissues work so differently. And so having specific models or appropriate models can really help us learn the things that we need to. And so staying in close communication with him, as well as the lung group, allows us to share models and share information in a faster way. At the end of the day, the goal is to help people. It's not to have rights or proprietary information. I'm willing to share all of these models with them as soon as they're available.
Well, and any oncologist is willing to talk to BRAF patients, like Dr. Kopet says. There's a whole bunch of doc talks in Colon Town with him, or Dr. Ryan Corcoran, and it's really impactful for patients to go, okay, maybe this makes sense. When he talks about synergy with chemotherapy and BRAF and Beacon, like going, really? And then when it actually turns out to be true, it's like, oh wow, that this is a game changer. So it's very it is interesting to find out that oncologists are actually some of the number one patient advocates out there.
Yeah, Scott's a great example of that. He's also a really fantastic mentor, and overall just great guy. So I'm a big fan.
Yeah, and he's also like I put in the chat the crcmrd.com site, and that's where he's looking for using ctDNA to find novel interventions that might be helpful to help keep from progression. Because like in colorectal cancer, 46% of colorectal cancer patients started as stage 1, 2, or 3. So there might be a time for intervention. And it's a different model in lung cancer because you all do use immunotherapy, whereas we don't. So it's like to find a way to like,
yeah, it's complicated because other than BRAF, actually my lab's expertise is never smoker lung cancer, not smoker lung cancer. And so we do a lot of work understanding those models. We've made models for never smoker lung cancer, and so we're trying to understand, when is immunotherapy right? When are targeted therapies right? How can we combine them in a more effective way? Melanoma has kind of led the field in understanding the timing, and when do you want to start with the targeted therapy? When do you want to add in the immunotherapy? Timing can be really important. There's a lot for us to learn. Especially if you're comparing or contrasting immunotherapy with targeted therapies or other combinations. There's a lot of directions to go, and lung cancer and colorectal cancer can learn a lot from other leaders and how they've gotten where they are.
Absolutely. So we have to wrap up. We went a little long.
I know sorry. I was just going to say, Dr. Rebus in melanoma sort of showed us that sequencing matters, and we can all learn from that.
Yes. Yeah. Yes, I know.
Absolutely. You guys, we could do this all day. Yeah. But I want to thank you so much, all of our panelists, Dr. Vaishnavi and our two advocate panelists. I just have, as we wrap up, one question. What do you want patients to take away from watching this video today? It can be anything.
I think
there's hope.
Yep, that was the word I was going to use first, is hope. And I think a community, you get hope with community. So the more we talk, the more questions we ask, the more we learn. I think that we'll, the better we're all going to be in helping each other.
I was actually going to say that too. She said it so eloquently, though. That's a beautiful way of saying it.
Oh, I was just going to say, watch out for ChatGPT. Go to actual experts.
Yes,
Yeah, there's a lot of
good
misinformation out
advice.
there. It's a danger, right? I have to
Yeah,
stop people sometimes.
right.
I'm like, just be careful. There's a lot of information out there, but there's also a lot of misinformation out there. Knowledge
Yeah,
is power, and Annie is a great example of someone who's really empowered herself to learn so much. It's amazing to hear. But sometimes people need guidance. On
yeah,
what the right sources are, what the right information are. So having tools and libraries and information for people is amazing. I'm also happy to help, if someone has questions on right resources or
yes,
places to look for information. Like for example, social media has a lot of information, but like if you follow specific scientists or people on Twitter or like companies or groups, it'll help you sort through some of the validated or proper information as compared to some of the misinformation that might be getting spread around because it can be dangerous.
yeah.
It
That's a
steals
great
your
point.
hope. It steals your hope, and you need, you need
Yeah,
to
no, that's
like
very
not
sad for sure.
serve
Absolutely.
it.
Absolutely. Thank you for bringing that up. Okay, finally, if you have lung cancer, here are my thoughts. Ask about biomarker testing, right? Including BRAF. If you are an advocate, keep raising awareness. If you're a clinician, keep testing, keep trials, keep working so hard. Thank you for working so hard for all of us. And if you need support, please visit the LiveLung website, livelung.org. And we also have a private Facebook group, Lung Cancer Network. Come see us. You're not alone. And we will be back again with more on BRAF. Thanks, guys.